Today is COPD and VO2 peak. So it's the same as last week, we're just changing the disease around. So you're going to see some similarities in the way that I present it. Not because I've been lazy, because I'm trying to teach you the way that I think is worthwhile presenting information. Now if you choose to use this sort of approach for your assessment, great. If you choose to use something slightly different, then that's great too. You can get firsts, whichever way you do it, as long as it kind of makes sense and it's all rational. Okay? So COPD. So I'm starting off by giving you some background information about this disease so you can start to understand, how it might influence VO2 peak and some of the other variables. Without providing you this information, it's going to be very difficult for you to really understand the sort of subsequent information that I'm going to provide. So COPD is sort of a number of diseases of the lung. It's really classified into two different sections, bronchitis and emphysema. So bronchitis is inflammation, so itis, of the bronchioles, So bronchitis, bronchioles, itis, inflammation. So whenever you see the sort of suffix itis, it always means inflammation. Tonsillitis, inflammation of the tonsils. Bronchitis, inflammation of the bronchioles. And so it kind of looks a little bit like this. So if we had a healthy airway there, which is nice and wide and patent, and then we've got somebody with bronchitis, and you can see there's like a thickening of the tissue of the bronchioles, and also some sputum that's gathered up, which is also causing some restriction to flow as well. So that's the bronchitis element of COPD. The other element of COPD is emphysema. Now emphysema is the breakdown of the alveoli, so those sacs that sort of at the end of your lungs, if you like. So they should have a nice kind of honeycomb pattern, a bit like a sponge. And that's really important because the sponginess of them, if you like, means that they can kind of constrict a little bit and then also open back up. And what happens when you get emphysema is that the walls of the alveoli start to break down. And that causes knock-on effect that we're going to talk about in a little while. But one of the things it does is it reduces surface area. So less surface area for gas transport into the blood. Okay, so we've got bronchitis, narrowing of the bronchioles, and emphysema, damage to the alveoli. And so you can have COPD where the predominant symptoms bronchitis, COPD where the predominant symptoms are related to emphysema, or a combination of the two. It's usually a combination of the two, it's just which one's more prominent than the other. Okay, so that is what COPD is. Some different sessions, but what causes COPD? So COPD is usually caused by some external thing irritating your lungs, if you like. So an external substance, usually cigarette smoke, but it could be other pollutants and things like that as well. Certainly, in the developed world, the vast majority of COPD cases are caused by cigarette smoking, either individually or passively. So these are a few statistics or statements that I've taken off the British Lung Foundation. You're most likely to develop COPD if you're over 35 and are or have been a smoker. And 8 out of every 10 deaths due to COPD are due to smoking. So if you don't want to get COPD, which hopefully you'll realise that you definitely don't because it's a horrible, horrible disease, stop smoking if you already do. It's my public health announcement for the day. Okay, so what does it do? So we know what it is. We kind of know how it's caused. You can go and sort of do a bit more research if you're really interested, but predominantly it's due to the cigarette smoking or what are the symptoms of it. So you can probably imagine what the symptoms are because they're the same kind of symptoms that you get if you get some sort of problems with your respiratory system. So people get short of breath easily when they're just walking or doing housework, so everyday activities. When they get a cough, it takes them a long time to shift it. So whereas it might take you 2 or 3 days to get rid of a bit of a cough, somebody with COPD can take them weeks. Wheezing in cold weather. So again, if anybody's got things like asthma, you sometimes associate either wheezing, sometimes it can become worse by cold, dry weather. And then also sort of like producing a lot of spit and sputum and things and coughing up things. So again, I don't know, I know someone with COPD, like early stages COPD, they've always got a cough and a cold. Because one, they're always coughing anyway, but then when they do get a cold, it stays with them for a long period of time. So it kind of, because it impedes their sort of like the natural process of clearing those diseases away. And they're also always coughing up things, big coughs in the morning. So, and it has 4 different stages. So although they're the different symptoms, the severity of those symptoms are going to be dependent on the severity of the disease that you've got. So it goes from stage 1 to stage 4, with stage 1 being mild COPD and stage 4 being very severe. So okay, so it's, you know, we can tell it has these symptoms, it's going to impair people's lives to some extent. But why is it important to us, or why is it important to the country, suppose? So one of the things is, so people with COPD, if you just look at those individual symptoms, it doesn't seem that bad. So you cough a little bit more, you might be a bit wheezier, you might have a cold a little bit more than that. But the symptoms go far beyond that. So the level of fatigue and the level of inability to perform activity can become incredibly profound when you get severe COPD, to the point where if it progresses so much, you end up in a wheelchair. And you're not necessarily in a wheelchair because your lungs are because of the primary lung symptoms. It's because your lungs can't work enough for you to be able to do the exercise. Like, they're just not functional. So what often happens is people become wheelchair bound. This person here is actually Mr. Spock. Can't think of his name now. Can't think of his name anyway. But he was a lifelong smoker, and so he ended up in a wheelchair. And what you might just about be able to see is in his nose, he's got a pipe running across, and that's consistently feeding in oxygen. So he needs oxygen all the time just to stay alive, or the most of the time just to stay alive. So it's constantly just feeding oxygen in through his nose, which is going to supplement the amount that's in his lungs, just to allow him to kind of function day to day. So that's the level that he's got to just through cigarette smoking. Leonard Nimoy, that's his name. And because of that, like, if you can imagine, if you're wheelchair bound and every time you need to try and get out of the house, you've got to be kitted up with an oxygen tank, tubes on your face, it's going to influence your ability to speak. It's also associated with social isolation, loneliness and depression, which you can kind of imagine, right? It's going to be very difficult for you to get out of the house every day just to go and get about your normal everyday life. You know, he's not working, right? He can't go and do a job as he is right now if he needs oxygen just to be pushed along an airport or whatever it is. So it's an incredibly sort of tough disease to have. I think one of the things about it as well, again, having seen people suffer from it, is that it's a really long disease, because you don't necessarily die of COPD like straight away. It can be a really long, progressive decline in your standard of living as the COPD progresses from that early stage to late stage. So it can take you 10, 20 years, where bit by bit you just become less functional and less functional until you end up like this guy. It doesn't happen overnight and then all of a sudden you die. So it's really, really long, prolonged sort of suffering, if you like. And it's not rare. So about 1.2 people currently in the UK living with some level of COPD. So a big number. So what's that, about nearly 2% of the population? So a fair old number. And then each year, almost 30,000 people die of COPD. So again, big numbers really. So it's important. It's affecting a large amount of the population. Lots of people are dying with it, and even if you're not dying with it, it's having a massive influence on your quality of life. Okay, so that's the first bit, right? So that's me just trying to explain why I think COPD is important to study. I'm now going to sort of, and maybe put it in a little bit in the context of it influencing, you know, physical activity and exercise capacity and things like that. I'm going to explore that a little bit more now by looking at how it affects some of the variables that we look at that give an indication of, you know, exercise capacity, so VO2peak. So this is a study here, and it's not a particularly good study, but it kind of set things out quite nicely for me to be able to present to you. But it's a study here by Gavji. So there's loads and loads of studies looking at VO2peak and how it's affected by COPD. Tons of studies out there, you find dozens. Like I said, this is not one of the better ones, but it has a nice figure which helps me be able to explain things to you. So what they've done in this study is really simple. They've taken people with COPD and they've separated them according to whether they had mild, moderate or severe levels of COPD. And they did that based on these guidelines, these gold guidelines that are in the kind of orangey box up there. And all the gold guidelines do is you have to have other symptoms of COPD, so like during a sort of assessment with a doctor. But then in order to try and sort of establish the severity, they look at your FEV1, so they do a spirometry test. So that's the one that you guys have definitely done, maybe last year, I'm not sure about this year, where you take a deep breath in and you breathe out as hard and as fast as you can. That first second is really important, because what that's kind of telling us is if you've got a narrowing of your airway, then you'll be unable to force the air out as quick as somebody who's not got a narrow airway. Okay, so the people with mild COPD have these other symptoms of COPD, but they have, following having a bronchodilator, so something that expands the bronchioles, they still had an FEV1 above 80% of predicted, so not too bad. Gold level 2, so the moderate, is an FEV1 between 50 and 80% of predicted, so quite diminished in comparison to what's expected. And then they put the other two groups into the severe category, so the gold 3 and gold 4. So everybody that's in severe 3 has an FEV1 lower than 50% of predicted. So really impaired post-bronchodilator, so post-medication designed to try and enhance the sort of diameter of the bronchioles. So more severe. So we're separating into these three groups. So group A, mild, group B, moderate severe, and then group C, severe. And they're just stuck on an exercise bike exactly the same as what we did, and then they've looked to see what their levels of VO2 peak are. Simple as that. And so they've done some prediction equations to predict what they thought they should be, and they thought they should all be about 40 mils per kilogram per minute. So that's their estimated VO2 peak based on their age, their weight, and things like that. I think that's slightly higher than what I would expect in this group because they're about just under 60 years of age. Hopefully you'll have an opinion on that again because you've measured this multiple times now. So you should have a sense of if you think 40 is high or low for someone's predicted levels if they're 55, 60 years of age. I think it's a little bit high. But anyway, that aside, the observed, so the measured VO2 peak is nearly 27 in people with mild COPD, about 17 in people with moderately severe COPD, and then 15 in people with severe COPD. So the point of this slide really is just to show you that as you get more severe levels of COPD, you get a progressive decline in your VO2 peak. So it looks as though having COPD influences your VO2 peak, and therefore that should be telling you in your head based on last week that it must be affecting one or more of those systems that allow you to take oxygen for the atmosphere and deliver it and utilise it in the muscle. Something must be impaired, otherwise COPD would be maintained at what it should be for someone of their age. This is COPD. They have impaired ability to deliver and utilise oxygen as determined by our VO2 peak value. And so this kind of feeds in to, again, like why we would want to look at this. So, okay, it's all well and good. People with COPD, it's not a very nice disease, kills lots of people. That's great. They have low levels of VO2 peak, so they've got some limitation in oxygen delivery utilisation system. And then we're going to find out a bit more about them, but why would we want to do that? So have a quick read of that. I'm not going to read it out because it's always sort of off-putting, but this is the kind of reason why you would start to do the studies that we've looked to do. Okay, so what it's kind of saying is, if we could establish where within that link from the atmospheric air to the muscle is having the biggest decline or an important decline on someone's capacity to transport or utilise oxygen, maybe we can target it for strategies to try and enhance their quality of life. Maybe we can give them medications that specifically target that area, or give them some exercise or some diet or whatever it might be to try and specifically improve that little bit that's not working as well as it should be. Okay, so our way of trying to look at this, you can do it lots of different ways, is to try and go through this process again. Because we know that oxygen can only transport in certain ways. The first way it transports is from the atmospheric air into your lungs through ventilation. So we did that last week and previous weeks. And then once that air and that oxygen is being presented at the alveoli, the only way it can get across into the blood is through diffusion. So that's the next step. We could try and understand whether COPD is affecting that. Then once it's in the blood, it's going to get circulated via perfusion. And then once that blood with the oxygen bound to it finds the muscle, then it's going to cross into the muscle, into the mitochondria through diffusion again. And then we could also try and understand whether something within COPD also influences utilisation, so the ability of the muscles itself to actually do something with oxygen once it's present. And hopefully, you might start to think, well, if we're going to look at COPD, a good place to start is probably going to be the top of the chain, right? So does COPD influence ventilation and diffusion? So that's going to be our topic of what I'm going to take you through today. But right from the offset, I'm going to tell you that COPD affects all of these. But what it's going to allow you to do is, if you really want to try and do a good report on COPD, there's lots of scope for you to focus on these other elements, develop them as your sort of primary question or something that you're going to look into, in order so you're not just telling me what I already know, if that makes sense. I'm giving you enough bandwidth for you to say, well, I'm going to focus on something else that's maybe more new and important, and I'm going to write about that. It's probably going to be better for an assessment point than just going through what I've already told you. Right, so let's start with ventilation. Again, hopefully this makes sense. It's a lung disease. The primary problem is something to do with the lungs. So let's have a look at that first before we move on to maybe some of the other stuff. So I'm going to use this kind of template, this idea that's put forward in this paper. If you do COPD, you should definitely go away and read. It's going to give you loads of papers to go and look at and give you a good overview of the problem with COPD with regards to exercising. And so they present this kind of like scales where there's this double problem, if you like, that's happening with people with COPD. And the problem is that they have a reduced capacity to ventilate. So they struggle to ventilate as much as they should be able to. But they also have a greater demand than they should have. So they need to ventilate more than what we would do for a certain amount of work, but they've got less capacity to ventilate. So it's like a double whammy. So if you had half of that problem, you've still got a problem. So if every time you do exercise you need to ventilate 20 or 30% more than you would do otherwise, that's going to cause some problems, right? It's more work that you need to do. But the problem for them, or the additional problem, is that not only do they have to do that extra ventilation, they've got a reduced capacity to do so. So we're going to kind of explore these relationships now. Bronchitis itself influences the diameter of your bronchioles and therefore causes an increase in resistance to breathing. So the top right hand figure there is a really simple one. You've got in the open circles is healthy people, in the closed circles is people with COPD, and then on the y-axis is just lung resistance. Okay, so it's a measure of resistance, and what you can see is lung resistance across all exercise intensities is about twice as high in people with COPD than healthy individuals. So lung resistance means that it's narrower. They've got to force harder to get the same amount of air out. Okay, so that's the first part. So the bronchitis itself causes an increase in airway resistance. Because of that increase in airway resistance, you alter your breathing pattern. It becomes more efficient to take shorter, sharper breaths in terms of overcoming the resistance to breathing. So this is what you can see in this sort of these two here. So we've got tidal volume against VE, and then we've got people, healthy people in the triangles, and then people with COPD in the circles. And what we can see is, well, two things. Healthy people are able to exercise for longer than people with COPD. But what we can also see is, towards the higher intensity exercises, that people with COPD in the circles have a lower tidal volume. So that means they're taking smaller breaths. Okay? And to combat that, the same figure here, but instead of tidal volume, it's breathing frequency. So to combat the fact that they're taking shorter breaths, they breathe more frequently. Okay, so their breathing frequency increases. So again, it's just a description of shorter, sharper breaths. More frequent breaths, but you're not breathing out as much each time. Okay? Now, the consequence of that is that taking short, sharp breaths is a really inefficient way to breathe. So if you think about it, if we've got an individual here, and so we've got, you know, the mouth, the larynx, the trachea, and then we've got some of the sort of primary bronchus here, all big airways which are needed in order to, you know, direct air from the atmosphere into the lungs, but they don't take part in gas exchange. Okay, so they're not taking part in nothing, they're not being used in order to take that gas and force it into the blood, or what's passively into the blood. Right, so if you're taking lots of short, sharp breaths, lots of the movement of the gas from the atmosphere into your body is all being done here, in this area that doesn't take part in gas exchange. Whereas if you take longer breaths and deeper breaths, it means you're clearing out much more of this air from your actual lungs. So when you breathe back in, you're sort of refreshing that air with fresh air. So deeper breaths are better in order to actually engage your lungs so that you can sort of freshen up that air for gas exchange. So if you do a short, sharp breathing pattern, it's inefficient for clearing CO2 or getting oxygen into the alveoli in order for gas exchange into the blood. So what you do to combat it is you increase your overall ventilation rate. So this is what this one shows here. So if you're breathing less efficiently, in order to combat it, you need to breathe more. So in the circles you can see for, say, 90 watts, the people with COPD have got a ventilation that's about 10 litres per minute higher than people without COPD. Okay, so just to go through that all one more time. So this is all about ventilatory demand, an increase in demand in people with COPD. They have narrow airways causing resistance. Because of that resistance, they adopt a different breathing pattern, which is short, shallow breaths, and more frequently. That short, shallow pattern is inefficient because you're not actually engaging the lungs, which is important for gas exchange. So in order to compensate, the people with COPD breathe more frequently. They have to, because they've still got to clear that CO2, and they've still got to try and present as much oxygen in the alveoli as possible. So in order to combat this inefficient breathing pattern, they breathe more frequently in total. So they have an increased demand. So at 80 watts, whatever it is, 90 watts, people with COPD have got to breathe at 10 litres a minute higher than they would have done otherwise. So they have an increased demand. And actually, to bring it into what we did in the lab, this would be the same if you looked at this and this was CO2. So they need to breathe more to clear the same amount of CO2. The VO2 slope, which we talked about in the labs. Okay, so this, if you put CO2 across here rather than work rate, you see the same sort of pattern, a steeper gradient. They need to ventilate more to clear the same amount of CO2. Okay, we measured that, so that's why it's probably important to have it in your head, because you could use it as part of your assessment, because we've measured VO2. Okay, so that's demand. So hopefully at that point you're happy that people with COPD have a greater demand to ventilate. They need to ventilate more for the same amount of work, for the same amount of CO2. What about their capacity to ventilate? How is that impeded? Well, what happens, this is a healthy individual first. So again, you may not have thought about this, but there's a test called an MVV, maximum voluntary ventilation. And this is a measurement, just very simply, of how much you can ventilate. It's like a performance test for your lungs. And the way you do it is you either sit down or stand up and you just breathe as hard as you can for a minute. Okay? And in healthy people, young people certainly, your MVV can be 200 litres a minute. So really, really high. Now, when you do an exercise test like we've done in the lab, you increase your ventilation progressively with exercise. However, when you get to your peak exercise level, none of you will have reached your MVV. And what that tells you is that you have a reserve in ventilation. You have a capacity to ventilate more, you just don't use it during exercise because you don't need to. Something else is stopping you from exercising. So every single one of you would have a breathing reserve, probably 50, 60, 70 litres sometimes. You can breathe more, but you don't need to. Now, in contrast to that, again, this is in health. If you think about it, it might help you make sense of it a little bit more, is when we look at something like heart rate, this is an example where you don't have any reserve. So if you look at heart rate, you've got a maximum heart rate of, say, about 200 beats per minute for most of you in this room. All right, again, it's going to be different for different people, but it's going to sit in and around there. You start exercising, you work at higher and higher intensities, your heart rate increases and increases and increases, and at the end of exercise, you all completely expect the fact that you could reach your maximum heart rate. And what that's telling you is that you've got no heart rate reserve, which is kind of indicative that you've got no cardiovascular reserve. Like your heart is working as hard as it can at peak exercise. And that's why we say it's a cardiovascular exercise test. Because in healthy people, it's testing your cardiovascular function. In someone with COPD, it's a little bit different. So in someone with COPD, the first thing to note is that their MVV is hugely reduced. So if we got them to do that same test where they say sit down and just ask them to ventilate as hard as they can for a minute, their values are much lower than they would be in a healthy individual. And how low it is dependent on the severity of COPD. But we put someone there at about 70 litres, something like that. Now, when you get someone with COPD to do a maximum exercise test like we did, they get the same response, a progressive increase in ventilation as exercise gets harder and harder. However, in people with COPD, not all the time, but a lot of the time, is they actually reach their MVV. So they reach their maximum capacity to ventilate. So you can imagine if you're doing an exercise test and you reach your maximum capacity to ventilate, and then you carry on doing exercise and producing more CO2, reducing the pH of your blood potentially, and then causing all of these signals and signs saying that you find it quite difficult, you're not going to be able to exercise for any longer, because now your ventilation is going to become a limiting factor. And if we contrast that with what happens with them with heart rate, is it's the complete opposite. So if you look at someone with COPD, well, if they're getting to their maximum ventilation before they get to their maximum cardiac output, maximum heart rate, well then often they have a reserve in their heart rate because they're not using it maximally. It's no longer a cardiovascular exercise test. They're being limited by their lungs. Okay, so what we've got is, just to summarise, in people with COPD, really the primary one we're interested in is this one here. They have a lower maximum voluntary ventilation. When they start to exercise at higher intensities, they can reach their maximum voluntary ventilation and therefore they need to stop exercising. So it's indicative that their capacity to ventilate during exercise is reduced. And we can kind of see this with these tests, these steady state tests. So this here on this side is kind of you guys and me. So healthy people who are doing exercise at different levels of intensity. So these dark bars, these dark dots here that go on to 120 seconds, somebody exercising at lowish intensity exercise. And so you can pretty much exercise as long as you want. Your VE goes to a certain amount and you hit a steady state. If you work at higher intensities, the pattern of your VE changes slightly, so it kind of goes up like that with the work, and then the white squares, you can see that someone is finishing exercise after say 3 or 4 minutes, and their ventilation's higher. But importantly, even in a really, really acute test like that, where you're working as hard as you can for 3 or 4 minutes, you're still not reaching your MVV. So you've still got a reserve. If you contrast that with someone with COPD, well, when they're working at really low intensities, they can have a similar response. So you can see the dark bars there, the lowest intensity, they're able to just about stay under their MVV, and so they're able to do some exercise. But as soon as they try and do exercise at a slightly higher intensity, they start to breach and hit their MVV and then stop exercising. And so you can see in each one of those, which is a higher intensity, as soon as they hit their MVV, they stop. And what this means is that if you reach your MVV, and so you can't ventilate anymore, but you're trying to do more exercise, well, it means you're not going to be able to keep increasing or maintain your arterial oxygen levels, alveoli oxygen levels, which means you're not going to be able to maintain your arterial oxygen levels, so they're going to decrease. It also means you're going to decrease your arterial oxygen saturation, which we measured, so you should be thinking about this. And it also means that you're going to get an elevation in your arterial CO2 levels because you're not able to clear that CO2 by extra ventilation. So, increased demand, decreased capacity. A recipe for disaster. So in addition to that, all of those things which are kind of really negative, they need to breathe more, they're not able to breathe as much, and therefore they're going to have to stop exercising, and then get feelings of dyspnea and sort of breathlessness really early on in exercise. They've got the additional problem that if you need to breathe more against a higher resistance, it means you have to use more of your oxygen levels and blood distribution to your respiratory muscles. And so what we've got here is a healthy person. I've got ventilation here on the x-axis, going from 10 to 80 litres per minute, and then we've got VO2 on the y from 0 to 2.5. And so when you all do your exercise test, again you might not have already thought about this, but the majority of your oxygen consumption goes to non-respiratory sources, like primarily the muscles that are doing the work, but also your gut and things like that are always going to have a baseline level of oxygen consumption. So most of it goes to non-respiratory mechanisms, if you like. And only a small amount goes to your respiratory system. And so kind of the number that gets banded around, the most you can really get to is in and around about 15% of your total oxygen consumption is delivered to your respiratory muscles during really hard exercise. But if you've got COPD, this relationship changes because you're now forcing against a resistance. You can see in someone with COPD, a much greater proportion of the oxygen consumption is going to the respiratory muscles at peak exercise. So if we put this into this sort of poor picture of health, they need to breathe more for a certain workload. They've got a reduced capacity to breathe at that workload, so it's already going to be difficult. And then on top of that, in order to breathe at that same workload, they also need to take some of the blood that should be going to, say, the legs to do exercise, and now they're delivering it to the respiratory muscles just in order to ventilate. So again, a recipe for disaster. It's all pointing towards the fact that the respiratory system is going to stop them from being able to do any higher level of exercise intensity. So, when it comes to ventilation, so COPD, so ventilatory capacity is limited in people with COPD. This impedes oxygen delivery to the alveoli for gas exchange, and the response to this high resistance is fast, shallow breathing, which causes higher ventilation and harder breathing, but is counterproductive because in order to do that, you need to take some of that cardiac output that should be going to other regions of the body and using it for ventilation itself. So it kind of impedes your ability to actually do the work you're trying to do in the first place. Recipe for disaster. Okay, so that's all ventilation related. We're going to move on quickly. It's a lot shorter, this bit, to look at diffusion in the lung. So it's a bit simplistic, but what we've done on ventilation is a lot to do with the bronchitis side of this. This is kind of more related to the emphysema side of things. So, diffusion in the lung. So the test to look at diffusion in the lung is it's a carbon monoxide rebreathing test. Obviously, you haven't got access to this information just so you kind of understand what happens. So in order to look at this, what happens is you take a big deep breath in of carbon monoxide, which should sound scary because it's not very good for you, but you only take a single breath and it's really diluted. And then what happens is that goes into your lung and you breathe it back out and it gets kind of collected in another gas. And what they're interested in is how much that carbon monoxide got taken up by your blood. And so it's a marker of lung diffusion. Because what you can imagine is, if your lungs are acting more efficiently, if you like, or more appropriately, you're going to be able to take up more of that carbon monoxide than a lung that isn't. So the higher the value, the better. And some of the things that affect the diffusion capacity of the lung are the things that affect any kind of diffusion. So if we've got in the top right-hand corner a healthy lung capillary sort of surface area, we've got like a nice big alveoli. We've got a really nice thin surface area, and therefore that's a good environment in order for all of those sort of oxygen molecules, CO2 molecules, or in this test, carbon monoxide molecules, to pass between the blood and the alveoli. So top right is ideal. Now, if we reduce the surface area, let's say because we've got emphysema, and we get a breakdown of the structure of the alveoli, well then that might look like this, a reduction in surface area. And so you can imagine, if we just look here, that now less of the alveoli is in contact with the blood vessel, there's going to be a lot less chance of those oxygen molecules or carbon monoxide molecules banging into the walls and therefore moving across. Okay, so it's a reduced surface area is going to impede diffusion. The other thing that's going to influence it is if you've got a really thick barrier between them, because let's say you've got inflammation in the tissue, then that's also going to impede diffusion from the alveoli into the blood. And these are the two things that are happening with emphysema. So a thickening of the tissue to some extent, but more prominently, a reduction in the surface area. So we would expect a reduction in the diffusion capacity of a COPD lung. And that's what we get. So the numbers up here, you don't really need to know them particularly, but if you looked at any study that looked at carbon monoxide diffusion across the lung in COPD patients, you're going to see this sort of thing. So 44% of the capacity than what would be expected for a healthy lung. Now, what is the consequence of that? Well, hopefully you can imagine that if you've got a lung and alveoli that are not functioning as well as they should be, well, that is going to impede oxygen transport into your blood and CO2 transport out of it. And so the one thing that we look at that kind of gives a bit of an indication of how well the lungs are working as a whole, but specifically to do with diffusion, is we look at this thing SpO2, peripheral oxygen saturation, the thing we use the pulse oximeter for. So if you think about it, if you've got an impedance to diffusion across the lung, that means there's going to be less that gets into the blood, less that binds to hemoglobin, and therefore a reduction in your SpO2. And this is important because we measured it. So we've got healthy people's SpO2 at the start and end of exercise, and I'm going to provide you with the people's SpO2 and the individuals that have got COPD at the start and end of exercise. So if you're interested in maybe understanding how COPD influences ventilation and diffusion, that might be a marker that gives you some information for your report. Okay, like I said, it's shorter. So for diffusion, emphysema destroys the alveolar membrane and some of the elastic fibres. It causes air trapping, which is not really gone into too much, but basically impedes ventilation and diffusion. The bronchitis itself is the ventilation side, therefore reducing the amount of oxygen that's being delivered to the alveoli. Both of these are going to influence diffusion. One because you're presenting less oxygen, and the other one because once you've presented the oxygen, there's not enough surface area there to sort of help move it into the blood. And these, in the stuff that we measure, are going to reduce things like arterial oxygen partial pressure, arterial oxygen saturation, and then maybe give you a rise in your arterial CO2 levels. And so hopefully the next question, if we go back, think back to those things. So we started off with, this is COPD. It affects VO2 peak. So somewhere within the system, it's affecting your ability to transport or utilize oxygen. We've been through ventilation. We've been through diffusion. We've touched really briefly on perfusion because we talked about how the respiratory system is stealing some of that blood flow and some of that oxygen, but we've not really sort of gone into it in too much depth. So the next questions are, well, what are the further effects of COPD on perfusion? Okay, what is the effect on diffusion at the muscle? What about utilization in the muscle? And I would say the muscle side of it, similarly to the heart failure, is where the majority of new research is happening in this area. So if you want to sort of like think about studying something, reading about something that's kind of more current, I've basically told you the stuff that's been known for a long period of time. This is the stuff that's emerging now. How does the muscle of someone with COPD change, and how does that affect their exercise capacity? So here's a few papers that you can look at. I would say this is a good starting point because it's a review. It gives an overview of all these things. Lots of those slides are taken from that review. This is just a link to explaining carbon monoxide rebreathing test, because you might see that in this literature quite a lot, so it might be worthwhile understanding. The top right one talks about how COPD can influence cardiac output due to sort of pressure changes within the lung, impeding the flow of blood. It's quite interesting. And then you've got the skeletal muscle stuff at the top left, and then oxygen extraction, so stuff to do with diffusion and utilization in the lung, in the muscle down at the bottom. So if you're interested in COPD, definitely go and find these papers and start off with that bronchitis, whatever it's called there. So in conclusion, COPD limits exercise performance and VO2 peak, so it affects our main outcome of interest. The primary problem is ventilation and diffusion issues in the lung, like that's the issue with COPD. But if you have COPD for a long period of time, it's going to have knock-on effects on the rest of your systems. So it's going to affect muscle perfusion, it's going to affect cardiac output, it's going to affect the enzymes that are in your muscles, all sorts of things. That's for you to go and explore. And if you're going to do this for your report, maybe sort of focus on, because it might be more interesting than just repeating what I've already told you.